Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds in Thoracic Surgery. I'm your host today, Eric Lim, and this is Premier Education brought to you at no cost thanks to our sponsors, Medtronic, AstraZeneca, and Medela, the Science of Care. This week, it's a great delight for me to present Professor Eugenio Pompeo from Vergata University in Rome to talk to us about a program that he has many, many years of experience in, which is non-intubated thoracic surgery. Eugenio, over to you.
Thank you, Eric. Good morning to everybody. It's a pleasure to join this session of the virtual grand round hosted by my good friend Eric Lim. We will talk about non-intubated thoracic surgery. And in fact, non-intubated thoracic surgery has been defined in several manners. At the beginning, we were talking about awake or tubeless thoracic surgery, which entails actually thoracoscopic procedure performed under spontaneous ventilation without tracheal intubation. Regarding the background, the history starts at the beginning of the previous century when surgeons started to operate under local anesthesia in awake subjects. The driving force was the experience ripened during the World War I, which has shown the soldiers might survive despite a traumatic open pneumothorax. As we all know, the scenario changed when double lumen tracheal tubes allowing single-arm mechanical ventilation were developed in the 50s, leading to abandon non-intubated thoracic surgery and becoming the standard anesthesia for thoracic surgery. You see here an old paper of a Russian surgeons who presented in Torino in an Italian Congress an experience about lung, heart, and esophageal surgery performed in awake subjects under local anesthesia in 1954. With ongoing experience with this kind of anesthesia, we also discovered the adverse effects of intubation and mechanical ventilation, which include, you see, so many potential problems like increased risk of pneumonia, impaired cardiac performance, neuromuscular problems, risks of major airway injury, and the so-called ventilator-induced lung injury. In fact, this kind of injury will cause several physiologic derangements in the human body and eventually resulting in the main physiological adverse effect of decreasing PaO2 and increasing PaCO2. So the renewed rationale for non-intubated thoracic surgery was to avoid side effects of intubation, general anesthesia, and single mechanical ventilation, to maintain more physiologic, muscular, neurologic, and cardiopulmonary status in order to minimize the overall procedure-related trauma and improve the outcomes. There are also several critical issues with this kind of anesthesia strategy. The first is that the open pneumothorax will cause a so-called pendular ventilation. There is a rhythmic diaphragmatic contraction because spontaneous ventilation is maintained. There is a risk of stimulating coughing reflex if the lung ileum is stretched. The need of thoracotomy plus intubation and lung expansion at end procedure can be a problem. Indeed, pendular ventilation can cause hypoxemia and hypercapnia. The diaphragmatic contraction can jeopardize fine surgical maneuvering, which can result more difficult. Cough reflex cannot be avoided routinely by an intrathoracic vagal block performed by the surgeon himself or herself. In case of uncontrolled hypoxemia, a supraglottic airway device, which is frequently used, it can be insufficient, needing intubation. And an emergency intubation can resolve difficulty in lateral position during major lung surgery. Regarding the problem of lung re-expansion, this has been fully resolved by application of negative pressure through the chest tube at end procedure. Our experience started in 2004 when we published this first work showing that lung resection were feasible and relatively safe, performed under local anesthesia. Epidural anesthesia was the regional anesthesia employed at that time in fully awake patients. And actually, so far, you see that almost all surgical procedures typical of thoracic surgery have been attempted or safely performed by non-intubated thoracic surgery, starting from surgical management of pleural effusion and proceeding with sympathectomy, bullectomy, lung volume reduction surgery, wedge resections, major lung resection like lobectomy and segmentectomy, and even sleeve lobectomy, tracheal resection, esophagectomy, and incredibly lung transplantation, which has been performed in China in recent times. Anesthesia also evolved over time. We have shifted and progressed from a full non-intubated awake anesthesia to the one that is more frequently used today, which entails a non-intubated anesthesia with a supraglottic device like a laryngeal mask. The patient has a target sedation, so is not awake, is sedated. Regional anesthesia evolved from thoracic epidural to more frequently employ intercostal or paravertebral blocks. The deepness of the sedation is monitored by bispectral index. We prefer spectral entropy today, and thoracic vagal block can be employed whenever necessary. So the evolvement of this story about non-intubated thoracic surgery has led us defining a change from awake to a so-called minimalist spontaneous ventilation thoracoscopic lung surgery. And in fact, we define as minimalist thoracic surgery evolutionary change of this strategy, including adoption of uniportal access, of less traumatic surgical technology, less traumatic anesthesia strategies, and whenever possible, avoidance of any chest tube placement. This is a case of a wedge resection performed without chest tube at the end of the procedure, but which can be a good indication, apart from the possibility to perform, as you have seen, all the procedure I've shown you, which can be the best indications for this anesthesia strategy. First, we have surgical procedures in which non-intubated thoracic surgery may offer simpler anesthesia management with equivalent results. Then we have some surgical procedure in which non-intubated thoracic surgery may offer superior results if compared to intubated thoracic surgery. And finally, surgical procedure in which non-intubated thoracic surgery may offer some oncological advantages due to a better preserved immune function. This is still under discussion. So regarding surgical procedure in which non-intubated thoracic surgery may offer simpler anesthesia, I would remind undetermined recurrent pleural effusion. This is a good, an interesting study published from the Toronto General Hospital, showing that this kind of strategy is not inferior, let's say, as compared to double lumen tube intubation, but the costs were less. Another simple procedure which can be perfectly indicated to be performed is a bullectomy for primary spontaneous pneumothorax. And in this regard, the most important study is this randomized, multi-center randomized study from China, showing that in fact, the non-intubated thoracic surgery bullectomy was not inferior to standard anesthesia, but decreased the costs, increasing then cost effectiveness of these procedures. Thoracic sympathectomy is another very simple procedure which can be perfectly performed under spontaneous ventilation. This is an example of a study showing better results in terms of hospital stay. Another important issue is surgical procedures in which NITS may offer superior results if compared to intubated thoracic surgery. We all know that undetermined interstitial lung diseases can be a problem if we must perform a simple wedge resection for diagnostic purposes. And we have shown, following the first study about feasibility in this retrospective multi-center study, that in fact, feasibility, was good with diagnostic yield of 95% and with no mortality. So this is the most important result of this retrospective study. In a meta-analysis, subsequently, we have shown several experiences about this topic, and overall there were 675 patients. Another important result is that also in this meta-analysis, operative mortality was nil, and diagnostic yields was nearly 100%. This is very important for a diagnostic biopsy procedure. Another interesting issue is undetermined huge mediastinal masses, in which intubation and general anesthesia with polarization may become a problem, if even the simple diagnostic purpose of this kind of biopsies. And in this study, we had shown in a propensity score matched small group that in fact the oxygenation was better in patients undergoing non-intubated thoracic surgery. Morbidity rate was better, but not significantly different. But overall, the results were maybe considered better and safer with this new anesthesia strategy. Lung volume reduction surgery for severe emphysema is in our hands one of the best indications for this kind of anesthesia strategy. We have a long story with this kind of strategy. In 2006, we published our first experience. Subsequently, in 2012, we performed a randomized study showing that in patients with non-intubated thoracic surgery, results were better, particularly regarding the perioperative status. We applied a new surgical method entailing not simple resection, but maximal sparing of the lung tissue, these delicate patients with intraflexive plication of the lungs to avoid sacrificing healthy tissue in this patient who has lost most of their functional tissue in the lung. You see in this study, more recent study, that the kind of ligation might be maximized by obtaining a quasi-lobar lung volume reduction surgery, and comparing three groups: the all-the-way group, the oldest non-away group with a quasi-lobar, hospital stay and residual volume was significantly better in the last investigated group. The most important result by this kind of strategy, I always stress this, is that very early after surgery, which is the most critical period for these delicate patients, you will see that about 1 hour after surgery, oxygenation is improving more than in patients, as you see with the blue line, with the non-awake lung volume reduction surgery. And you see that by non-intubated anesthesia, 1 hour after surgery, oxygenation is coming back to the preoperative status, so they can safely go to the ward without entering in an ICU. And also PaCO2, which can increase instead at end procedure due to pendular ventilation, will come back to the pre-op value 1 hour after surgery only. For lung volume reduction surgery, we apply a staged procedure. You see here an example of a preoperative severe emphysema, upper lobe predominant, cigarette smoking related. 12 months after surgery, the right side plicated lung is readily visible on the chest CT scan, and the bilateral treatment 12 months after left-sided treatment. Interestingly, we recently analyzed our results in 110 stage bilateral procedure. There was no operative mortality, and no patient went to the ICU. I believe few experiences can show this data so far. Bullectomy is, of course, a simple procedure which can perfectly be done under these kind of strategies. And then the last important hope is surgical procedure in which non-intubated thoracic surgery might offer some oncological advantage due to better preserved immune function. Lung metastasectomy has been proposed by our group in 2007, and we also investigated the immunologic function in the early postoperative period, seeing that natural killer cells were better preserved, and then interleukin-6 spillage was less following non-intubated lung metastasectomy. This may create some hope about an oncological rationale for this kind of strategies. Regarding lung cancer resection, this is a critical issue in our hands because you see in this recently published table that most of available data are regarding retrospective studies, and in most of these, the primary outcome was even not indicated. Nonetheless, you see in this study coming from an important group, the one from Yangxing in Guangzhou, that for the first time, long-term results in terms of overall survival were better following lobectomy and segmentectomies performed by non-intubated thoracic surgery. This is in direction of a potential beneficial effect about the oncological results in these kind of patients. Another good indication is thymectomy excision of mediastinum tumor. We have reported a small series, and in this table you see that there are some relatively important experiences in this regard. Let's say that the most of the advantage I can see in this kind of surgery is also for patients with associated myasthenia gravis, which can benefit more of these safer and less traumatic anesthesia strategies. So in conclusion, if we look at the scientific evidence about the potential advantages of these surgical strategies, you see that there are some encouraging results, even though results from large multi-center study are still lacking. There is a reduced need of high dependency stay postoperatively with a relatively good evidence. Data shown in unicenter randomized studies or in retrospective studies, including propensity score matching analysis, better perioperative respiratory function and oxygenation, reduce operative morbidity, shorter hospital stay. The only data shown by larger multi-center randomized study is lower procedure-related costs in the study published about bullectomy for primary spontaneous pneumothorax. And there is also some evidence of attenuated immune response impairment and better survival in oncological surgery. So if I may attempt some take-home messages, I would like to share these. We need to standardize indications for simple non-intubated thoracic surgery procedures, including management of spontaneous pneumothorax and pleural effusion, in which intubation and one lung ventilation is potentially avoidable. Someone has defined in these cases this kind of anesthesia strategy as an unnecessary luxury. Second point, standardize indications for non-intubated thoracic surgery procedures that can offer the greatest advantages. Let's say patients requiring biopsy or resection with interstitial lung diseases, lung volume reduction surgery, management, surgical diagnostic management of patients with bulky or huge mediastinal masses, most often lymphomas, and patients at high risk for intubation while lung ventilation. We also need to investigate further indications for major surgical procedures, which is the most critical issue in my opinion so far, in patients with and without comorbidity, taking into consideration risks related to difficult fine surgical maneuvering and emergency need of conversion to ergotomy plus intubation due to unexpected complications, vascular major bleeding or something like this. Finally, investigate comparatively the effect of non-intubated thoracic surgery on recurrence and survival in cancer surgery due to the potential beneficial immunologic effects in the early postoperative period. Thank you very much. I will invite all of you, if one likes, to our hot parade in thoracic surgery hybrid workshop that is starting today here in Rome. Thank you very much for your attention.
Thank you very much, Eugenio, for a great presentation. I've got, maybe I'll start with some initial questions. How good must the intercostal blocks be or pain control before doing the actual non-intubated surgery?
Yes, let's say that intercostal block is very effective in our hands for pain control, particularly when we adopt a uniportal access. And let's say that in most of the simple procedures, we actually adopt a uniportal access. So intercostal block is very good.
Excellent. Thank you very much. And many of the audience are asking what range of operations can be done. So Dr. Jethani, Dr. Addy are asking wedge resections, pneumothorax surgery, can all this be done using non-intubated surgery?
Yes, as I told, we may discriminate procedures for which intubation, double lumen intubation, despite the standard, is not always necessary. So we can speculate the non-inferiority of non-intubated thoracic surgery in these instances. On the other hand, in other procedures, it can be beneficial.
Excellent. No, I agree with you that non-intubated is non-inferior in the majority. But in one setting, I think it's superior, which is tracheal resection. Because in tracheal resection, if you have if you have an intubation and paralysis and you lose the airway, then the patient dies. Whereas, He Jianxing in Guangzhou, as you mentioned, has done the operation of tracheal resection with spontaneous ventilation. So then you lose, or you have an additional layer of safety for the operation.
Yes, I fully agree with you, Eric. I've seen Jianxing doing a tracheal resection, and I didn't mention more deeply tracheal resection because of the still limited experience. But actually, surgical maneuvering in tracheal surgery is much facilitated by non-intubated thoracic surgery management. I fully agree.
I personally don't have enough experience in non-intubated to dare to do that on a tracheal resection, but I can see the actual definitive advantages in that setting. There's a question from Dr. Jazani who's asking, if you have a vascular injury in a non-intubated patient, how do you manage the LMA, or do you go into intubation to manage the vascular bleeding or something bad happens? What's your protocol for safety?
Yes, it depends by the kind of injury. Of course, if the injury can be managed thoracoscopically, we can avoid conversion to intubation and double lumen tube ventilation. If the injury is really serious and we need a thoracotomy, we usually prefer to intubate the patient in lateral position and then and simultaneously perform a thoracotomy.
So your anesthetists must be quite skillful in intubating in the lateral position, huh?
Yes, this requires some experience, but with the available devices such as the video laryngoscope is not so difficult today, let's say.
Excellent. Dr. Therese is asking, when you do the non-intubated surgery, what structures in the chest must you not touch to avoid coughing or issues during the operation?
Yes, I think it depends by the procedure first, because there are procedures during which high lung manipulation is more frequent, such as for major lung resection. In these cases, the intrathoracic vagal block is much effective in eliminating this problem. In other procedures, it is not necessary. For example, during lung volume reduction, we never perform a vagal block because we don't have an iron stretching during this kind of procedures.
So the vagus block blocking the vagus nerve will help reduce the coughing reflex during the non-intubated surgery?
Yes, we use the intrathoracic vagal block by a long needle, and we block the vagus in the highest level that is possible, which means above the aortic arch on the left and the highest possible on the right side.
Dr. Pinto is asking, what do you think causes patients to stay in hospital shorter and lower the cost with the non-intubated surgery?
Yes, the shorter hospital stay is related to an earlier post-op recovery. The patient can start oral feeding and drinking and oral feeding in the day of surgery, immediately going back to the ward, is staying in the recovery room less time. And so in most of these procedures, the patient might go home the day after surgery.
Excellent. Dr. Jethani is asking, what's the reason for better survival in the non-intubated surgery patients, do you think?
Well, it's difficult to say, and I think it's too early to make some real statement on this regard. There is some evidence, but it's really a few. We need more investigations showing that in the early post-op period, less traumatic anesthesia might better preserve immunological function and result in less stress hormone-related impairments.
Thank you. Dr. Alad Mashi is asking, when you go into the chest and the lung is fully inflated, when you go with a non-intubated surgery, does it automatically deflate or must you wait? And if so, if it doesn't deflate quickly, what can you do to help the deflation?
Yes, I think that everyone should try at least once, because what you will see is that in lungs with the nearly normal lung elastic recoil, you will see that the lung collapse will be fully total, as well as you will see with the double lumen tube intubation. In other instances, such as patients with severe emphysema, this is not the case, because due to the hyperinflation of the lung, they still remain hyperinflated somewhat even during the open pneumothorax.
This non-intubated surgery to me suggests that there's a great potential for day case surgery in the future. What is your view of using these techniques going forwards for letting patients home on the same day?
Yes, I fully agree on this hypothesis. We actually are limited so far to the day surgery in thoracic surgery because in Italy, for example, it doesn't exist. If you are admitted for thoracic surgery procedure, you have to stay in hospital at least for one night. So, but many procedures might be done, let's say pleural effusions, sympathectomy, many wedge resections in a day surgery setting.
Thank you very much. As always, there are so many questions and not enough time for answers. Which leads me to thank our sponsors.
Thank you for the invitation. Thank you to everybody.
Not at all. Thank you very much
It's
to our sponsors, AstraZeneca, Medtronic, and Medilia, the Science of Care. And next week, we have Professor Martin Kaplan talking to us of an update on neuroendocrine tumors. Eugenio, thank you very much. Have a very successful conference today. Always an amazing conference at Vergata. We all look forward to your discussions and the publications that follow.
I hope to meet you soon. Bye-bye. Thanks.
Bye-bye.